Hello, everybody. Thank you for joining us for today's BU Industry Insiders webinar, Technology, the Magic Bullet for Healthcare's Problems. My name is Jeff Murphy, and I'm an Associate Director in the BU Alumni Relations Office, as well as a proud alumnus of the BU Questrom School of Business. Today's webinar is sponsored by the BU Alumni Association and by the Questrom School of Business Health Sector Management Program, and is offered to our 300,000 alumni around the globe. With BU Industry Insiders, the Alumni Association highlights successful alumni thought leaders showcasing their work on emerging trends and advancements in fields that Terriers work in. It's important to us that we get your opinion on how we're doing, so we very much look forward to receiving your feedback via a survey that will be emailed to everybody later today. Please know that we really do value your opinion on this and every program we offer. Before I introduce today's speaker, some brief housekeeping notes. As you know by now, this webinar is being hosted on the Adobe Connect online meeting platform. If you experience any trouble with the audio or visual portions of this presentation, I'm going to ask that you please contact Adobe Connect directly, and I'll give you that number if you want to jot it down. It's 1-800-422-3623. Today's presentation is being recorded and will soon be made available for on-demand viewing on the BU Alumni Association website, found at www.bu.edu/alumni. Our speaker today is very eager to answer any questions that you may have, and you're welcome to submit them throughout the presentation using the Q&A chat box you see located at the bottom of your screen. We hope to get to as many questions as we can during today's webinar. Now it's my pleasure to introduce our speaker for the day. Presenting today from right here on campus is Questrom School of Business MBA alumnus Scott McLean. Mr. McLean began his career at General Electric and has 25 years of experience in information technology. He also served as a campus chaplain in New York City, which has given him unique perspective on human interaction and the implementation and application of technology. Mr. McLean currently serves as Deputy CIO and Director of IS Operations for Partners Healthcare here in Boston. He's responsible for the core technical infrastructure teams and administration of the Partners Information Systems Department. This includes the voice and data network, data centers, desktop support, and service desk for many of the Partners hospitals and affiliated ambulatory practices. He oversees the budget, space, and HR needs of a 1,500-person department. Scott, we're really excited to have you. Thanks so much for spending time today with us, and I'm going to go ahead and turn it over to you.
Thanks very much, Jeff. Good day to everyone. Jeff gave you some of my background, and I just wanted to highlight a few things about it that have given a perspective on this. I purposely ended the title with a question mark because I think that technology in healthcare is a very vast subject, and we'll cover some of that today and some of the ideas that I have about it, and we'll hopefully generate some conversation with you all and get your perspectives as well. Jeff mentioned obviously the MBA from Questrom. I have a background in electrical engineering and then spent a fair amount of time at General Electric. He also mentioned the campus chaplaincy, which gave me a unique perspective on how people interact with technology, among other things. And then the last many years here at Partners Healthcare in Boston. At the same time, I also had the great opportunity to participate in the Healthcare Information Management and Systems Society, or HIMSS, for many of the last 20 years or so, and this is a professional society dealing with the disciplines of the intersection of technology and healthcare and life sciences. And because I wound up as board chair of that organization, I had a chance to travel fairly extensively to places you see here listed on the slide, and that has given a very good perspective and will end up informing my assumption and hypotheses going forward. Before we get started, I'd just like to get an idea of who is in the audience today, and Jeff is going to put up some poll questions to figure out who is in the audience. So we're going to ask whether there are physicians, registered nurses, folks who are working in healthcare IT, or maybe you don't work in healthcare. I see results coming in, so several folks who work in healthcare IT. I didn't see any physicians or nurses. I want to have a very respectful attitude towards those clinicians as I feel like their roles are extremely important in the whole system. And part of my hypothesis will have some questions about how those roles move forward in the system.
Scott, I apologize. I accidentally made that poll go away, probably a little bit premature. I promise I won't do that on future poll questions.
No worries, Jeff. It just was good to see who's tuning in. So this is the assumption and proposition I'm going to put forward for you all today, given my travels and experiences, which is regardless of what type of culture or payment system exists in countries, everyone is looking to improve healthcare quality and reduce costs. And so far, from what I've seen, healthcare IT is seen as a non-partisan, non-politically partisan enabler to meet these goals of improving quality and reducing cost. So just to go over some basic healthcare systems issues, these are things that probably people read in the paper day in and day out. Most of what I'll talk about here is US focused, although I think that there are similar issues in other countries based on how healthcare is paid for. And there seems to be no free lunch in all of this. So people may or may not know, back in 1999, the US Institute of Medicine created a report called To Err is Human. And the big takeaway from this report was that it was believed that up to 98,000 deaths occur in the US unnecessarily because of the healthcare system. And then there were follow-on reports about how we could attack this and improve our quality in the system. We still hear lots of commentary in the media and other places about how US healthcare quality isn't up to what we'd hope it to be. But I think there is evidence of improvement. We certainly see that within our healthcare system, and there are measures that show across time how I think we know that people are living longer and we are able to deal with diseases that we haven't been able to in the past. So there is some positive nature of the quality issue. What's really in focus is that the costs are increasing and outpacing inflation. It's making it difficult for US companies to compete internationally. And I have a chart that shows how, at least here in Massachusetts, it's crowded out government budgets for other opportunities for spending, at least over the last 15 years or so. And then we've tried, at least in the US, various payment systems searching for value. We want to be able to have the best quality, obviously, at the lowest cost, a value equation. And so traditionally, healthcare has been paid, physicians have been paid fee for service. They get paid for what they do. And that, of course, has, at least in theory, allowed some overusage and physicians wanting, in some cases, to utilize more services in order to get paid. And I don't look at that as a negative, purposeful negative thing, but rather a result of the system. Then there were changes in the inpatient payment system in the 1980s. DRGs are diagnostic-related groups that are for inpatient reimbursement. At least here in Massachusetts, we tried a thing called capitation in the 90s. This is really getting a budget to a certain fee per member of a health insurance plan per month. And I think this was not well received here in Massachusetts, where it caused some underutilization and some horror stories of patients not getting cared for as they should. Pay for performance goes back to a fee-for-service basis, but also puts in some incentives for quality and other performances that are met. Again, this has some downsides because it still is based on fee-for-service. Health benefit redesign, we've seen in some of our offerings for health insurance that there are tiered offerings where you might get a higher copay for going to a certain provider that's more expensive. So that's an attempt to impact how we utilize the healthcare system as patients. Prior authorization, this has been used for high-cost imaging and other services such that a physician or clinician needs to get prior authorization from an insurance company. And of course, you can imagine what kind of response that gets from a physician who's trying to take care of patients and doing what they know is best. Budget-based risk is coming about as a result of some of the Affordable Care Act provisions. People may have heard of the term accountable care organizations, where there is a budget set up to take care of a population of patients, and then if targets are met and there is savings, then both the payer and the provider share in that savings. Of course, if there's downside risk, both the provider and payer lose in that, share the loss in that. Defined contributions, similar to how pension plans changed over the years, there is talk about employers and other agencies giving us as patients and consumers a defined amount of money to be able to spend on healthcare exchanges, and then have a choice of how we might want to use those healthcare dollars depending on our health and habits. And then finally, bundled payments are being discussed, and these are best utilized in procedures like joint replacements, where the entire episode of care, from preoperative appointments and screening through the surgery and the rehabilitation and follow-up, is all covered under one payment. And there are some large companies that are experimenting with this by saying that their employees can get these procedures only at certain institutions, as they've negotiated a bundle payment for that procedure. So now a few graphs about some of the economics. This graph, US only, from 1960 till 2010, you can see this is healthcare spending as a percentage of GDP, which is up around 18%. These are the kind of numbers we're reading about in the paper day in and day out. I will say again that I think healthcare outcomes are generally improving. It depends on what metric one looks at. As I mentioned earlier, people are living longer. And there's also several pieces of evidence that show that as wealth increases in a population, we tend to spend more money on healthcare itself. So often here in Massachusetts, people talk about that we have a high cost of healthcare, which may or may not be true. One thing that is true is that it's about in the middle of the US in terms of healthcare spending versus income of Massachusetts residents. Then this next page, this graph from the Kaiser Family Foundation, shows a clear difference from back in 1999 up until 2013. You see how inflation has gone on the bottommost chart. And then the next one up is workers' earnings, and of course the big delta between workers' contributions to insurance premiums and health insurance premiums. So this is obviously showing how this is an unsustainable outcome. And then I talked earlier about crowd out. This is a Massachusetts graph, and this shows from fiscal year 01 to 14 in Massachusetts. And you see on the left-hand side, the Massachusetts spending on our Medicaid program and other medical insurance programs here, and the increase, which is the dark blue bar versus the gray bar, and then how all other spending in areas of the government have had to go down to be able to make up for that spending in healthcare. So this is obviously a real issue for states and municipalities, as they are spending more on healthcare and less on things like education, infrastructure, and public safety. So then I'd like to talk about the evolution of healthcare IT, at least from my hypothesis. And again, this is where I'd like to say that I think I'm here and I do my work to serve physicians and other clinicians, and I have a lot of respect for them. So that's the premise I want to put out there. I think they have a hard job. I think that physicians are in charge, and they should be. But I think some of the ways that the industry has evolved didn't serve us well. And so, like many professions, the government and the public expect a profession to police itself and take care of itself. We have this joke that doctors' handwriting is very messy, and I suspect that's because they're very tired from all the training they've gone through, among other things. And then I want to make this hypothesis that doctors' quote orders has squelched IT innovation. And what I mean by that is that doctors being in charge have wanted to do what they want to do, and sometimes workflows can be very personal in how people want to practice medicine. So my way of thinking about this, and I've helped develop healthcare software over the years, is that if you line up 10 doctors and ask them how they want something done, you might get 20 answers. So the hypothesis here is that the way that the healthcare software environment has evolved is because fundamentally physicians have resisted adoption, and that may be for some very good reasons. So in the past also, there were fewer protocols, there were fewer ways of knowing from the science what the best way to take care of a patient was. I think that's becoming, at least for some conditions, more and more able to be protocoled, and knowledge bases can help clinicians, physicians, and other clinicians make their treatment decisions. I think also that the current healthcare knowledge, which grows every day, is just too vast for any one person to keep in their head. So this is also something that computer systems can help with. So what's happened because of this is that there are really two private companies that have dominated the high and low ends of the market, at least in terms of market share. And I think that's unusual for a market that such a large and important thing such as healthcare software running hospitals and ambulatory practices have two private companies at the top end. There are also conglomerates. When I talk about conglomerates, I mean large companies like GE and Siemens who have largely failed at this as they have tried to enter this market for healthcare software. And then there are innovative companies that have really tried to enter and have made progress in various parts of the healthcare software market. And I see that at least one of them is on the webinar today. I think it's been difficult given the heavy investment of these monolithic systems at the hospital level, and as that's increased with integration to the ambulatory areas. And then there are what we call interoperability challenges. So I think this has been incented because over time, providers have wanted to keep patients. We certainly in our company want to keep our patients in our network and serve them across the ambulatory, acute, and non-acute spectrum. This makes it easier for us to care for them and less expensive. And then I think these vendors have also obviously wanted to keep their customers. They have wanted to sell all of their software into a specific area. And so neither side has been incented to be able to share information between the two. So I think that some of why this is changing now is the various government actions that has taken place over the last several years. So people may or may not be aware of the HITECH Act, which is part of the 2009 American Recovery and Reinvestment Act. And this was a notion where the Department of Health and Human Services had formed an Office of National Coordination for Healthcare IT. And the philosophy coming out of that was that if you believe that healthcare IT improves quality and lowers cost, that what we'd need to do is have providers adopt technology, then do something called meaningfully using it, and there were parameters and are parameters to measure whether hospitals and physicians do that, and that this would drive outcomes, better outcomes, both in terms of quality and cost. And I think that you probably in the popular press can see questions from the public, from employers, and even from the healthcare community and from Congress about whether we're getting the outcomes from this investment. I would say, working in this field, that we need to give this more time, and that I do believe that those outcomes will come from this adoption of these technologies. So the analogy that I like to use about this is that going back to whether this profession polices itself, this is really, we're trying to automate a profession here. And perhaps it is a little bit different than academia or law because there is more science, at least for some of the care that physicians and hospitals deliver these days. But if you were to give an analogy, you might say that that physicians in hospital environments are like the faculty in a university. Hospital administration would be equivalent to the university administration. The payers would be like the parents, and the patients are like the students. And those incentives don't always line up well. So I think another example would be if you were saying to a professor in a university level, hey, we've got a way of making sure that your students get educated better and you'll get better feedback on your course evaluations if you plug your lesson plans into this software and utilize it this way, then you'll have good outcomes. And the same thing if you asked a trial lawyer to do similar preparation for a trial. There's a lot of art in how these professionals do their work. So in healthcare, I think the balance of how physicians use and other licensed professionals use protocols and use software for clinical decision support versus how they use their own judgment for diagnosis and therapies. And certainly this would be different depending on the severity of what the illness is and whether one is in an academic and research environment where there is constant experimentation going on for improved therapies. Also along this, I think that there are market issues. This gets into the disincentive between who pays and who consumes. And I think that it is, for most of us still, at least in the US, the payment for healthcare is blind to us because it's usually covered by a government program or by our employer. I realize there are outliers to that still. And so that market disconnect between, there are few other services that we buy that we're so disconnected from who pays for it, especially a good that is of such consequence as healthcare. And then in my travels, always when I speak with physicians, they talk often about the regulation and reimbursement issues. So obviously, for good reason, healthcare is extremely regulated, not only at the federal level, but also obviously at the state. Medical licensure is usually at the state level. And so physicians and others are hampered by practicing across state lines, and it's difficult to get reimbursed for new technologies. So one might believe that you can use a new technology for an online visit, a virtual visit. I've heard it said from physicians that they gave up the telephone, that they don't get paid for their telephone consults. They don't want to give up their interaction with patients over the web. And you certainly can understand how physicians would want to be able to get paid for their expertise. So what are some of the technology possibilities? So the electronic health record, and this is largely coming about, at least in the US, because of the HITECH Act and the adoption. We've seen significant adoption both in inpatient and ambulatory areas. It really provides for shared, accurate documentation that multiple disciplines can use in the care environment. It provides for continuity of care between ambulatory, inpatient, and non-acute settings, and ties in all of the necessary revenue cycle with those different care areas. I know, at least in our case, that we are looking forward to larger research data sets and weaving in big data possibilities with this using social media and other databases. And it will provide for a richer recruiting mechanism for clinical trials when appropriate and patients are informed and consented. We can use these clinical trials and research data sets to advance the progress of medicine. And we're hearing about the Internet of Things, various wearables. I have a Fitbit Surge on my arm right now and can monitor my heart rate and other activities. And I think as these things move forward, we're going to be asking questions about what should be our patient, or dare I say consumer, participation and obligation as we participate in the healthcare system and work to maintain our own health along with the healthcare system. And then there's a lot of talk, obviously, about disruptive technologies. The ones that I hear that come up most often are the Airbnb and Uber examples of companies that have come into the hotel industry and the taxi industry without any assets, just using software and the power of the internet and the mobile devices that are so ubiquitous. So the question is, what is going to be the Airbnb or Uber of healthcare? And of course, a lot of this is limited by the regulation and reimbursement issues that I mentioned earlier. I do think that these technology possibilities do include improved quality and lower costs. Improved quality because we have more knowledge that can be cataloged and applied to care settings. The research and clinical trials issues that I mentioned earlier. Costs come down just because overall I think we can be more efficient because of the data being in the right place, and we can use more protocol. We can ensure that care takes place in the appropriate, least expensive setting by the appropriate licensed clinician. So here's a set of questions that they're designed to get us to think a little bit about how we interact with the healthcare system as consumers. And so Jeff's going to put up a poll for the first question. And so the first thing we are asking about is why we don't expect to pay at the doctor, and maybe one of these fits you, whether healthcare is a right and should be part of our tax payments, whether we believe our health insurance should cover it, or maybe we do plan to pay for it, but we just don't want to deal with it when we're sick. We'll take care of it later. So most people are voting for the fact that their insurance should cover it, and I think still for many Americans that's the case. So then we'll have another question about how we might change that incentive later on. Next question is why we tolerate not being able to book our appointments, pay bills, and ask questions or chat online with our doctor. So maybe we feel like we don't have that choice. Maybe we don't want to have a relationship with our doctor like we would with our airline or our bank. We want it to be more personal. Or maybe healthcare is so different we just never thought about it. So there's a very strong direction towards providers like the one that I work for. 90% of you are saying you feel like you don't have a choice. And so that is certainly something that we want to change in our organization and make better for everyone. And then the last one, Jeff, is about what it would take for us to change our personal habits. And this gets into the first question where we talked about why we feel like we should have to pay or not to the doctor. So some of the bills that we're expected to pay at the doctor get into that change in health plans. Some high-cost imaging has higher copays. What would it take for us to change our behavior and how we take care of ourselves? Would it be a very high coinsurance fee as part of our income? If our employer or the government program we are part of gave us a defined contribution or a significant health event? So the results that are coming in show that most people would change their behavior really around a significant health event, that the payment is not something that would send people to change behavior. Great, thank you very much. So just by way of wrapping up, the expected next steps, I think, are that we are going to continue to see, whether it's commercial insurance or government programs, more demand for consumer engagement. This is certainly part of the provision of the 2010 Affordable Care Act, where I mentioned earlier the risk-based budget payments for healthcare include accountability for both the payer and the provider. And a lot of questions come up about how can we as consumers participate in that as well. So I think there will be increased interest from payers, but also from us as the payers push more responsibility and risk to us for payment. And then in terms of technology limitations and concerns, there are many of them. I'm sure people are well aware of the headlines all the time about cyber threats, and it's certainly something that all healthcare companies and virtually all companies need to be, and organizations, aware of and working to protect against, and that's a whole other presentation about how we can defend ourselves and take care of that. Another issue with this moving more towards consumers taking risk is that, will we as a population be able to manage this risk? Will people fall through the cracks because they're given a defined contribution and don't buy the right level of health insurance or need for provision? And could it be possible that clinicians will continue to resist adoption? They may break away from the payment models. In some ways, we have a two-tier system today because some folks can pay up in order to get more services. We have concierge medicine, where folks are paying a fixed fee to see their doctor for anything that they want at any time they want. Of course, some of these things are limited by the regulations and the reimbursement policies that may come forth either at the state or federal level. So that is what I wanted to share with you all. Jeff wanted us to spend plenty of time doing questions and answers, so that's what I think we should turn to now, Jeff.
Great. Thank you, Scott, so much. Again, a reminder to everybody, feel free to use the Q&A chat box at the bottom of your screen to type in some questions. We've already had a couple come in, but please go ahead and type those now. While we're allowing a couple questions to come in, Scott, I have to say from a university standpoint, I think your analogy about your university analogy is fantastic. I think we're already seeing how technology is changing higher education, with the costs soaring for a college degree. A lot of universities are already experimenting with blended models of online learning combined with classroom learning, and I think it's something that we'll continue to see develop. So I personally, that really sort of was an interesting thought-provoking
So,
thing for me.
so there are 2 points there. I think it's the automating a profession. How much can you apply protocol and software to a profession like medicine, law, or academia? And then as a parent of one college student about to have two, I'm looking forward to the focus on expense changing to academia from healthcare at some point.
Fantastic. So we do have some questions that came in. Catherine is wondering, and I'm paraphrasing here, obviously, healthcare, how do you take into consideration the emotional investment people have with this subject? In other words, life and death and the concept that someone's life is in their hands. Though data supports, a certain healthcare decision, people might not trust software to dictate care. How do you respond to that?
Sure. I think that the first thing that we would say, and any physician would say, any clinician would say, is that the software is not making the decisions. The human being who's trained to make those decisions is utilizing clinical decision support and knowledge bases to be informed, to make the best diagnosis and then apply the appropriate therapy. As a side note, I should say there is research being done on how electronic health records can cause errors. I would say from my experience, the error rate from electronic health records versus what it was like before computerized physician order entry and electronic medication administration records, there's a big offset there. So the benefit of having these systems, I think, really helps the care processes in terms of safety. And then I think that the inability of any one human being to have all of this growing body of knowledge in their head, that's the benefit of having systems like this.
Great. Noreen's wondering if you see payers and providers collaborating more and more effectively to engage patients or members and improve outcomes.
I certainly hope so. There has been some of that in the various payment systems that I've talked about in the presentation. And increasingly, as providers and payers share more risk, obviously it incents to collaborate better. And then there are models in various parts of the country where providers actually own insurance companies or have a payment component along with it, and they're regulated differently, and they're set up to maximize obviously their quality and to be able to pay for the care for their member population as best as possible. So I certainly think as we move forward, whatever's decided at the federal level from a payment and Medicare, Medicaid insurance process, that there would be collaboration, involvement, and cooperation with the providers for the best outcomes for the patients.
Got some great questions coming in. Thank you, everybody, for chatting in here. Do me a favor, just try to keep them short to maybe one sentence or a sentence and a half. Jamie's commenting here on something that also struck me in one of our poll questions, Scott. Jamie was shocked that most people reported in the poll that they would only change health-affiliated behavior in the event of a healthcare emergency. Jamie's worked for the World Health Organization on applying social behavior studies to healthcare seeking incentives, and she's found that there's strong evidence indicating that payments would inspire behavioral changes. How do you think, Scott, that this applies to healthcare, IT, and beyond?
Well, I think I was a little bit surprised by the poll, and it's a non-scientific poll amongst the several of us in this chat room here. I just think about my own behavior. If I went to my primary care physician seeking an MRI because my knee hurt, and he said, "I don't think you need an MRI," And I'd say, well, I want the MRI anyway. And he said, okay, it's $500. I would say, well, maybe I don't think I need that MRI. So I think that and where HIT can come into play in this, I know in our system, we're fortunate to have a couple of different radiology imaging support systems that we were actually able to get a waiver from pre-authorization for high-cost imaging because the clinical decision support systems utilized, the insurers trusted that the information the system was bringing forward um, saved or directed the clinicians towards appropriate image ordering. So I think that's one area where HIT can help there.
And another area where, a question about how technology can help maybe lower costs. How can technology help educate patients before a procedure? For example, consent by watching a procedure video, or how to best prepare for a procedure. Any other thoughts on that?
Well, I think there's a huge opportunity here, and happily there are some entrepreneurial type companies that are leading out in this space, and I think this is another area based on that poll question that I did about where patients and consumers feel like they don't have a choice. I think we as providers can do a much better job at adopting technologies where folks can securely log on from home and again become educated about an operative procedure, um, be able to sign consent forms. Of course, the trick for us is being able to support that interaction with a patient, because as someone commented in an earlier question, it's not just like buying a book from Amazon or ordering an airline ticket. These can be very personal interactions and upsetting. So being able to have a internet interaction that is, again, lots of privacy and security issues. We need to ensure that patient identification issues for their patient safety, not to mention fraud issues and other items like that. And then to be able to have trust again in the content that is being presented to the patient, and ensuring that the patient understands it and is able to consent to it, and that is the appropriate substitute for a face-to-face interaction with a clinician who might be going over the same materials.
Scott, I know when we had first talked about your presentation that you thought or predicted that some of your comments might be taken as controversial. And Christina, I'm going to go ahead and guess that you work in healthcare. Christina's basic question is about the human interaction and the importance of that in the doctor-patient relationship. Is IT going to be something that prevents a doctor from being able to look a patient in the eyes? Is the time spent with a machine or eyes on a screen going to provide distraction? So long story short, how do doctors and healthcare providers overcome this, knowing that IT might actually decrease face-to-face time between care providers and patients?
Well, it's a very common question that comes up, and I've been doing this almost 20 years, and I certainly, my experience with physicians and other clinicians is that they very much want that personal interaction with the patient to not be disrupted. These folks are very bright, they're very competent at what they do, and they also don't like their time wasted. So they want good workflows, whether it's with paper or electronics or whatever they're doing as they're interacting with patients. And so I would say that that's a principle that we take very dearly about how can we preserve that interaction between clinicians and patients and streamline their workflow, reduce the number of clicks if they're using an electronic system. That's something we work on day in and day out, and I believe that the vendors, the manufacturers of the software, take the same spirit. The other side of it is when I got my start in this industry, it was working out of a significant negative event that happened at one of the hospitals, and part of the belief was that the human interaction with preparing the therapy was inadequate and could be better and certainly more safely prepared using electronic systems for order entry. And so I think that's the other side of the patient interaction, is recognizing that the physician or other clinician is using the electronic medical record and its associated clinical decision support and and database behind it now as other diagnostic tools that she or he may use in the diagnostic process, and that's a very important thing for being able to get an accurate diagnosis and to get safe care.
Scott, I've never seen this many questions come in on one of our webinars before, so congratulations on that. I'm glad we left some extra time. Are you okay to keep going with more questions?
Sure.
Okay, perfect. So Rachel's got one. With the healthcare information technology market being dominated by two major vendors, how is it possible for the extraordinary upfront costs of healthcare IT purchase and implementation to become more reasonable investment for both large hospitals as well as small and rural practices?
It's a good question, and I should say that there are two major vendors, market share at the top and bottom, and I struggled with that word bottom, but there's one of them, is seen in many of the academic centers, and the other private one is seen in a lot of the community hospitals have really deep penetration. There are 3 or 4 other very significant vendors in this space, along with many smaller ones that cater to specialty care and ambulatory practices. So I think this is one of the big questions in a market like this, and it's one of the points that I was trying to get at about how it's different, perhaps, than other industries and other software markets. But I think if we went and studied how enterprise resource planning software that market shook out, it would also have a trajectory where you have innovators and startups, and then mergers and acquisitions, and finally a shaking out of the market. So I think in this space, it's still got a ways to work itself out, just like I was talking about with the HITECH Act, where we had adoption, meaningful use, and then eventual outcomes. I think in this case, and I tried to get at how the healthcare providers interact with software manufacturers, that process has been not as market driven and not as streamlined as other industries. And so I think it's taking long. I think we got a later start in terms of automation. And then I think the ways that clinicians interact with the software and help to develop it, that's what's taking longer for the shakeout of the companies that will ultimately be the provision of healthcare software, and ultimately drive down the cost of the software itself, but make the adoption of it and utilization of it easier. I mean, the example that I think, at least when I was a CIO of one of our hospitals, I'd walk down the hall and physicians would say, "Well, why doesn't it work like an Apple? Either a Mac or an iPhone?" And well, lots of different things there, right? I mean, Apple fundamentally is still a consumer product, and we're looking at enterprise, robust, secure software. And then the App Store concept, I think, is a great one for the various types of disciplines that medicine has. But I think that the market forces and the workflows between inpatient, ambulatory, and non-acute space has not allowed that freedom, at least as of yet.
I'm going to try to combine a number of questions that have come in. Scott, you mentioned that there are, two companies that sort of dominate the space, and if you could go ahead and name those companies, and then if you're willing, could you also share the names of some of the companies or products that are sort of up and coming that maybe you're excited about, or put on your crystal ball and mention some of the products that are out there that might sort of help change the future of healthcare IT?
Well, so I'll answer the first half. I prefer not to speculate about or talk about my preferences just because of my position in my company. But
sure, fair enough.
Yeah, so I think the top end system that I was talking about is Epic, and I think that there are other systems in that. Well, I'll just name the other one I was talking about was Meditech, which is a Massachusetts company, and then Cerner, Allscripts, McKesson. Those are the biggest hospital healthcare software vendors, and they all have various components of revenue cycle systems and ambulatory systems or affiliated software programs they work with to make the whole package available. And then I mentioned GE and Siemens too, that exited the market in recent years. That you'd think companies like GE and Siemens and Philips and other conglomerates like that would play well in the space and just haven't. So that was really the point I was trying to make there. I think in the innovative software market and the smaller the smaller area, I think what we've seen happen is, again, when you talk about a physician's workflow, I've seen some great, like at the HIM show every year, you see some great specialty software that's developed by clinicians, and maybe it works very well for them, or maybe it works very well across their specialty. And then often what I've seen happen is that that smaller company will get purchased by one of these bigger ones, and then the specific wonderful nature of that workflow might be at least dispersed because it's integrated in with the larger software program that's offered from one of these bigger vendors. So I hope that that sort of answers where I was going with that.
Yeah, and we had a couple people who've chatted in about questions about Epic specifically. And would you be willing to comment on how satisfied you are with Epic's new patient gateway?
Well, that's a hard question. So the the MyChart functionality that Epic delivers can be sort of vanilla out of the box from Epic, or it can be combined or housed amongst other components. Um, so it really depends on the healthcare system that deploys it, and what type of patient interaction that is offered, because there are choices obviously in how providers, what they expose, and what types of options that patients have. So that's what I would say about that. I mean, in terms of partners and our provision of a patient portal, we've had one for many years, and it had its specific abilities for patients to get results, to book appointments, to ask for referrals, to communicate securely with their physician. And as we're implementing our new next generation electronic medical record, we are implementing components of that that electronic medical record into our partners patient gateway. So we're trying to keep the site that our patients already knew and add to it.
Great. Jack's wondering, with the Affordable Care Act, more people are entering the healthcare system, and primary care physician panels are squeezed tighter. What opportunities do you see for technology to help with that?
Well, so I think that this is really depends on the local market. So this is one of the things that you hear, that healthcare is local. It just varies so greatly by even region of a state, not to mention across state lines. I do think there's opportunity for, and again, this is where some of our discussion and the questions have been, for the relatively healthy, for the simple issues where you can be pretty confident that the knowledge bases and protocols that can be applied. You see this with pharmacies offering clinics that are staffed by nurse practitioners instead of physicians, very convenient consumer hours versus doctor's office hours. And I think that there's an opportunity for it to both meet the quality needs and provide the convenience that consumers want, and also have a less expensive practitioner relieve the burden of the PCP primary care panels by doing this. And of course, there are going to be concerns, by the public and by others about, well, what about the cases where you trust that particular practitioner and you have a misdiagnosis, or there's something more catastrophic that's wrong, that is missed and lingers. So those are the trade-offs, and I think states and authorities are trying to make the best decisions to enable these types of facilities without putting the public at undue risk.
So we have an alum, Andrew, who is working at Athena Health, who has written in with a question. Do you see a near future where interoperability and provider collaboration is commonplace? And would you share your thoughts on Commonwealth Alliance?
So where interoperability and provider collaboration are commonplace,
Right.
and then a comment on Commonwealth. So my feeling about this, and thanks for the question, that the Athena Health person is very knowledgeable. I saw that they had dialed in. Um, my feeling about interoperability is that we've been talking about this for a long time, and my joke is that people are seeking the interplanetary medical record. And again, most healthcare is local. Now we're obviously, there are incentives in the HITECH Act and the Affordable Care Act about sharing information so that we don't need to do repeat testing and these types of things. I think in our case, for my provider organization, where we have needed to build interoperability to do the best care for our patients, and frankly, at the least expensive cost, we have built and supported that interoperability amongst our owned entities and our affiliated care partners. So I think that really the end game for interoperability is driven again by a market force, not by something that is uh, what I want to say, less just put forward as a philosophy or an idea. And so again, I think as consumers bear more risk, as providers bear more risk, there's more incentive to share information. You know, you get a test done at one facility, you want to be able to view those results at another facility, or you're passing on continuity of care documentation to the next facility that needs to care for the patient. So I think there's been a real loosening, and this is partly incented by the recent legislation uh, amongst the vendors to be able to share data, and frankly, providers are demanding that more, and consumers will demand it more. In terms of alliances like Commonwealth or other even state regional health integration organizations, or um, you know, various ways that like Massachusetts has something called the Mass Highway to connect physicians and hospitals. I'm skeptical, I guess, that these can sustain themselves, and how much of those are ideas that people have about a desire to share and interoperate versus being able to, or having a business need or a clinical need to share clinical data at an appropriate cost.
We've got a few more minutes here, so Scott, if it's okay with you, we'll just keep trying to get through as many questions as possible.
Sure.
Awesome.
Hot topic.
Sorry, what's that?
It's a hot topic.
Yeah, absolutely. So Claudia has asked about can IT be tailored to help elderly patients with various medical problems? Do you see a middle layer between healthcare providers, patients, and IT providers to manage the IT, but also provide a personal touch to the end users?
I certainly think it's possible. Some of the work that's been done in our Partner Center for Connected Health has had technical technical interactions with elderly patients, remote monitoring for blood pressure and other parameters has been done, at least on a pilot basis, and some more ongoing basis for us. So again, not everything is monolithic. We can tell about some of our population, their response to our patient portal and various technical interactions. And while the elderly set might have in general a harder time with technology, it's certainly not the case across the board. And it's a curious idea. I don't know how it would be easy to provide that middle layer of support for the elderly, um, without adding significant expense to the equation. So, the expense you'd gain by using remote technology for monitoring or whatever else, if it can't be used effectively and you need support for that, then it negates the cost savings. But I think that it's certainly something that for certain interventions we've found that we've been able to be successful for all types of patients.
Cam has written in with an interesting question. I'm a wearable user myself, and so Cam's wondering if you, how you see wearables making an impact down the road. Currently, patients analyze their own data, but physicians either don't know that it's been collected or aren't able to, spend time sifting through it and make it truly usable. So, do you see hospitals looking into how to implement programs that are better suited to use data collected from wearable devices?
So I think that discovery is going on right now. Again, we've had some in our organization, some experimentation with running patient data into our electronic medical record and having a clinician approve and choose whether it's accurate and appropriate to use. So I think that there is more time that needs to take place to have those things evolve. Although, as I mentioned earlier in the presentation, we are looking at larger and larger data sets, including social media information that can be de-identified and aggregated and utilized to support the whole care process. I do think with our individual wearables and the information that we're getting as they become more sophisticated and tied into the healthcare system, that that is driven again, I think, by how much pressure comes on us as patients and consumers. So if we're told our insurance premium is going to be higher if we don't exercise, and we can prove that we exercise by using a wearable, then we're going to demand that providers accept that information.
So thank you again, everybody, for chatting in with great questions. Unfortunately, we're not going to be able to get through all of them, but we'll take this one last one from Catherine. Catherine's wondering, how do you see the C-suite role in driving the adoption of healthcare IT? In her experience, if there wasn't much push from above, it causes a slower implementation or just falls apart completely. So what's the, somebody like yourself, a deputy CIO, what is your role in making these changes?
Well, it's a good question, and I think that it's an accurate statement. I mean, I guess in the time we have remaining, I'd make a quick reference to Kaiser Permanente. And when I heard their CEO speak at one of the HIMSS conferences several years ago, and they started on their electronic health record journey. It's over a decade ago when they began, and the CEO went from one health system to another, knowing that that's what he needed to have the appropriate systems to generate the appropriate data to make Kaiser successful. And so then when he was making this speech at HIMSS, he was talking about the data that they had collected. And I'll forget exactly what the stat was, but they were convinced that if they could get their population of members to walk 30 minutes a day, that they could reduce the incidence of diabetes by X%. And so that's how they were utilizing it. I do think it takes the very top of the organization to push these things. And happily, within our organization, it did not come about from IT. This was a CEO level initiative that started our second generation EHR.
Well, Scott, I'm really glad we left a lot of time for questions. I mean, the fact that even in this online platform, we were able to turn this into sort of a conversation, I'm just thrilled. So thank you again for spending this much time and sharing some of your experience with the alumni community. I really appreciate it.
Thanks, Jeff.
I also want to send a big thank you to Ned Reimer, who's the faculty director of the BU Health Sector Management Program, for his work in arranging today's webinar. My thanks also go out to all of our guests for participating. We've got some great webinars coming up over the next few weeks, including one next Tuesday called Working with Difficult People. I'm sure nobody has any experience with that. You can sign up for that session now on our website at bu.edu/alumni. And as always, if you or any BU alumni you know would be interested in presenting a professional development webinar or have a topic that you'd like to showcase for the BU Alumni Association, please feel free to contact me directly at the Alumni Relations Office or by email at jtmurphy@bu.edu. Thank you, everybody, for your time. Have a great day or a great evening wherever you might be.